There are few cataract patients who present to you with a cataract so dense that you have to think twice before proceeding for phacoemulsification. And in these scenarios, you may also consider if manual small incision cataract surgery may be a choice, looking at the hardness of the nucleus. So this is one patient who presented to me with other eye being pseudophakic, which was operated few years back by me, and the patient waited so long for this eye that this cataract became something like grade 5 and beyond. So patient had some amount of astigmatism, so a definitive incision meridian was decided, and while making an incision there were a few incidents. You'll see them. I was switching to some new blade which was not so sharp, so there was uncontrolled sharp entry which traumatized the capsule also, which you'll see just now as we have stained the capsule, and we can see a small flap which has been raised by the incident keratome. So proceeding to use this as a nick for creating a flap, and as we proceed, I didn't expect this to be a phacomorphic variety, so I think that the capsular axis was well in control. But as I proceeded, I found that at the terminal point of the capsular exit, it simply extended out. So I put in more viscoelastic to flatten the capsule and then proceeded to see if I can bring back the axis. But it was obvious that it was not possible. So I proceeded to use 1/2 scissor to trim this end so as to cut off the capsule and create a axis. So now this was a point where I had to think whether I should proceed with phaco or should I switch to manual small incision cataract surgery, which might have been safer. But then I decided for phacoemulsification, and using the burst mode, I buried deep into the nucleus and tried to create a primary horizontal chop. And this was not a complete chop, but then the second one gave me an edge and the surgery could be proceeded. Now one thing I would advise for those who want to attempt phacoemulsification in such hard cataracts is that usually the inhibition is about burying your phaco tip deep into the nucleus, and that is something which causes formation of a posterior backbone of the nucleus which remains there and keeps the pieces being held together. So the most important thing is to reach deep into the core of the nucleus when burying your phaco tip so as to get a good purchase, and that will be detrimental in providing you the complete separation of the fragments. Another important thing is to create more than 4 pieces so as to have the chunks which are smaller and they don't protrude into the anterior chamber or come close to the corneal endothelium if one wants to avoid post-operative corneal decompensation. Going for removal of the cortex, and cortex removal in compromised axis is little tricky because one has to take care you don't catch hold of the capsule edge because it is not round, and it may be confusing to that it blends with the cortex, so that one has to take care that to identify the capsule and the cortex clearly separately. Proceeding for implantation of a monofocal hydrophobic IOL. This is a preloaded IOL. So the IOL goes directly into the bag, and just confirming that it is in the right place. Now proceeding for removal of viscoelastic, which has been done, and now sealing the wound. Now the litmus test for these kind of procedures is the next day cornea. If the cornea is good and there is no wound burn at the termination of the surgery, that means it is a good surgery. And this is the patient at day 1 post-op, where we can appreciate a clear cornea, a centered IOL, a dilated pupil which has been dilated using a mydriatic, and the visual acuity which was 6 by 12. Thank you.